Hi, my presentation focuses on the female reproductive system and on a disorder that is quite prevalent, that is the polycystic ovary syndrome. And I'll be focusing on the physical, mental, and general well-being outcomes and on the psychological management of the syndrome. The female reproductive system is a complex network of organs and hormones responsible for reproduction, hormonal regulation, and general well-being. The female reproductive anatomy includes both external and internal genitals. Internal parts include the ovaries, which are oval-shaped glands located at either side of the uterus, which produce eggs and hormones. The fallopian tubes are narrow tubes that are attached to the upper part of the uterus and serve as pathways for the egg to travel from the ovaries to the uterus. Fertilization of an egg by sperm normally occurs in the fallopian tubes. From here, the fertilized egg moves to the uterus, where it implants into the uterine lining. The uterus is a hollow, pear-shaped organ that holds a fetus during pregnancy. It is further divided into cervix and corpus, where the corpus is the larger part of the uterus that expands during pregnancy, and the cervix is the lowest part of the uterus. A hole in the middle of the cervix allows sperm to enter and menstrual blood to exit. The vagina is a muscular canal that joins the cervix, so the lower part of the uterus, to the outside of the body. The external parts, so the external genitals, protect the internal parts from infection and allow sperm to enter. The vulva is the collective name for all external genitals, and the main parts are the labia majora, which enclose and protect the other external reproductive organs, the labia minora, which surround the opening to the vagina and urethra, which is the tube that carries urine from the bladder to the outside of the body. The clitoris, which is a sensitive protrusion that provides sexual pleasure. The vaginal opening, which allows menstrual blood and babies to exit the body. And the hymen, which is a piece of tissue covering part of the vaginal opening. The female reproductive system has several essential functions, primarily focused on reproduction, hormonal regulation, and overall health maintenance. Specific to the function of reproduction, the ovaries produce and release mature eggs through a process called oogenesis. And once per cycle, the most developed egg is released in a process called ovulation, preparing for possible fertilization. The fallopian tubes provide a site for fertilization, and if fertilization occurs, the zygote begins its journey towards implantation in the uterus. The uterus provides a nurturing environment for a developing embryo, supporting nutrients and oxygen. And the uterus also contracts during labor, pushing the baby through the cervix. Another main function of the female reproductive system pertains to hormonal regulation. And if fertilization does not occur, the uterine lining sheds through menstruation, allowing the cycle to reset. And these menstrual cycles are typically regulated by the hormones produced in the ovaries, mainly estrogen and progesterone. The estrogen hormone also supports secondary sexual characteristics. And further, to contribute to the hormonal regulation, we also have testosterone, which supports libido and muscle function in females. Lastly, but not least, the female reproductive system is also responsible for the overall health maintenance of women individuals, where estrogen protects against osteoporosis and cardiovascular disease, overall supporting bone and heart health. But also hormonal balance, generally speaking, is very important for mood and cognition as it impacts emotional stability and memory. It's very important for sexual health as it supports libido and sexual function. And it's also very important for the metabolism as it influences the fat distribution and the insulin sensitivity. Overall, beyond reproduction, the female reproductive system is vital for hormonal harmony, for physical health, and for mental wellness. The female reproductive system can be affected by various disorders ranging from mild to severe. These problems may impact fertility, menstrual cycles, sexual health, and overall well-being. Here, I focus on polycystic ovary syndrome. Polycystic ovarian syndrome is a complex disorder that affects women by causing menstrual problems, ovarian cysts, infertility, and potential long-term health issues. Polycystic ovary syndrome may increase the risk of developing other health conditions, such as diabetes. This disorder affects about 10% of women of reproductive age, making it the most common disorder of women within this age range. Estimates may vary depending on the diagnostic criteria that are used. And here you see estimates that are according to the Rotterdam criteria. However, estimates also may vary based on ethnicity. For example, we know that indigenous Australian women and South Asian women have a higher prevalence than Caucasian women. And also women that are overweight may present a higher risk of developing polycystic ovary syndrome. While the exact cause that underlies the development of polycystic ovary syndrome is unknown, we know that there is usually a hormonal imbalance where high androgens like testosterone disrupt ovulation and cause the typical symptoms of the syndrome. We also know that up to 70% of women with polycystic ovary syndrome have insulin resistance, which leads to high insulin levels, which further increases the androgen production. And we also know that typically there is an imbalance between the luteinizing hormone and the follicle stimulating hormone, which are both pituitary hormones essentially for the reproductive processes. This imbalance prevents proper egg development, which leads to the characteristic ovarian cysts. We also know that genetic factors underlie the development of the syndrome, and we know this because oftentimes the syndrome runs in families. And also certain gene variants, we know that certain gene variants affect hormone regulation and insulin sensitivity. Further, the development of the syndrome may be underlined by metabolic issues, where insulin resistance causes per se the ovaries to produce more androgens. And insulin resistance can lead to type 2 diabetes, weight gain, and difficulty losing weight. Chronic low-grade inflammation, which is often present in women that present with this syndrome, also may stimulate androgen production. And lastly, environmental and lifestyle factors may play a role, and specifically, excessive body weight worsens insulin resistance and hormone imbalances, but also lack of exercise contributes to metabolic problems, and high sugar or processed foods can spike insulin levels, and chronic stress increases cortisol, which worsens insulin resistance. The symptoms of polycystic ovary syndrome go beyond just cysts. That is the typical, phenotypical symptom that we associate with the disorder. But the symptoms really affect hormones, metabolism, and mental health. To name a few, we've got irregular or no periods, or prolonged periods. We have excessive hair growth, which is also called hirsutism, which is due to elevated levels of androgens, which produce unwanted hair growth on the face, chest, and back and thighs. We also have acne and oily skin, particularly on the face and upper body. Oftentimes, the syndrome is associated to gaining extra kilos, and so unexplained weight gain is not uncommon, and also it's not uncommon to face an inability to lose weight. It's common to experience thinning of hair with hair loss or thinning of hair on the scalp, similar to the male partner of baldness. And it's also common to experience patches of darkened skin. So where the skin really darkens in the neck, groin, due to insulin resistance. And it's also important to notice that not all women have the same symptoms. So some may have no cysts, some may have no weight issues, and a combination of all the options is also possible. From a psychological point of view, women with polycystic ovary syndrome are 3 times more likely to experience depression and anxiety than women without polycystic ovary syndrome. Contributing factors may be hormonal imbalances with the presence of high androgens and insulin resistance, body image issues due to hirsutism, acne, and weight gain, and fertility struggles and stress from irregular periods and infertility. They may also experience poor body image and low self-esteem, with symptoms like excess hair growth or hair loss and obesity, leading into social avoidance, lower confidence, and increased risk of eating disorders such as binge eating or emotional eating. Women with polycystic ovary syndrome may also experience chronic stress and emotional dysregulation. Indeed, many women with polycystic ovary syndrome report to have mood swings, which are linked to hormonal fluctuations and feelings of hopelessness due to difficulty managing the symptoms. Lastly, women with this presentation may report a reduced quality of life, as polycystic ovary syndrome negatively impacts sexual satisfaction due to body image concerns or pain, social relationships, where isolation may come from embarrassment feelings, and also work productivity due to the presence of fatigue and brain fog from insulin resistance. This meta-analysis provides valuable insights on polycystic ovary syndrome by highlighting the connection between physical and mental health and by describing the effectiveness of cognitive behavioral therapy in addressing pathology-related mental health issues. CBT is a psychotherapy that modifies cognitive patterns and provides behavioral restructuring to alter psychological symptoms and behaviors. CBT has been successful in the treatment of various illnesses, including obesity, depression, anxiety, eating disorders, insomnia, and other chronic disorders. While several studies have explored cognitive behavioral therapy as an intervention for polycystic ovary syndrome, this is the first meta-analysis to systematically explore its efficacy. This research aimed to synthesize evidence from 8 studies to assess whether CBT improves key outcomes in women with polycystic ovary syndrome, including psychological well-being, measured as anxiety and depression, quality of life, weight management, treatment compliance, and pregnancy success rates. 2 authors searched PubMed, Cochrane Library, and Bayes, clinical trials of Gov, CNKI, and Wonfeng data for studies that dated up to 19th of November 2020. Inclusion criteria included polycystic ovary syndrome had to be diagnosed according to recognized criteria, such as the Rotterdam criteria. Studies included randomized controlled trials and cohort studies. Studies had to include at least one treatment condition that was described as a CBT intervention or that was based on CBT principles, such as where the patients were taught cognitive skills like identifying automatic thoughts and cognitive distortions. Studies had to include control groups which underwent lifestyle modifications or routine treatments, such as medications or standard care. Lastly, studies had to provide sufficient data to calculate effect sizes regarding changes in weight, depression, anxiety, and quality of life. Studies were excluded where a full text was unavailable or if they were overlapping. A total of 1,820 studies were identified as potentially relevant. Out of these, a total of 1,099 articles were screened and 461 duplicates were excluded. By reading titles and abstracts, 1,047 articles were excluded and 52 articles were further assessed in full text form. After the assessment, 44 articles were excluded by conforming to the inclusion and exclusion criteria. Finally, 8 trials that matched all the criteria were analyzed in this meta-analysis. So, what were the findings of the meta-analysis relative to the efficacy of CBT managing polycystic ovary syndrome psychological outcomes? Changes in depression were reported in 4 trials. But in these trials, patients' depressive symptoms were not significantly improved when compared with control groups. Meanwhile, anxiety symptoms were studied in another 4 articles, and in these studies, CBT resulted in significant improvements in anxiety symptoms. Quality of life, defined as a multifactorial concept that encompasses physical, emotional, and social aspects, was also assessed in this study. And CBT was identified as improving patients' quality of life in aspects of hirsutism by the meta-analysis findings. However, no effect was identified when analyzing differences in quality of life referring to menstrual problems, infertility, social aspects, weight, and emotional aspects between CBT-treated patients and controls. Referring to secondary outcomes, patients' compliance level and clinical pregnancy rates were identified as being improved in the CBT treatment groups when compared to the control groups. So, to summarize the findings, this meta-analysis revealed that CBT on women with polycystic ovary syndrome improves anxiety, quality of life, particularly related to aspects such as hirsutism, improves compliance and pregnancy rates. However, it does not significantly improve depressive symptoms, does not significantly aid weight loss, or improves other aspects of quality of life. In previous literature, CBT has been well established for anxiety and depression management. Regarding anxiety management, the meta-analysis findings align well with other existing literature. However, the same is not true regarding depression management. Unlike in previous studies, CBT alone did not significantly aid weight loss in polycystic ovary syndrome patients, but combined with lifestyle interventions, it may help. And lastly, CBT's role in improving compliance reflects findings in other chronic conditions where it was known to help sustaining behavioral changes. Overall, a clinical psychologist can play a significant role in managing polycystic ovary syndrome related symptoms with specific relevance to the psychological symptoms. Using a CBT informed intervention, a clinical psychologist can target cognitive distortions, so thoughts such as I'm ugly because of my hair growth, challenging negative self-perceptions. It can also teach behavioral strategies, thus helping stress reduction and favoring the establishment and the maintenance of healthy routines. But it can also complement medical treatment, so working alongside diet, exercise, and medication, so overall lifestyle modifications. More broadly speaking, a clinician can play a role in integrating CBT into a broader polycystic ovary syndrome management by, in the first place, identifying the psychological needs of the client, so screening for depression, anxiety, body image, and other concerns, but also by collaborating with therapists and overall promoting a holistic care, so encouraging CBT, like we mentioned before, alongside lifestyle modifications and medical treatments, which have shown to be some of the most effective strategies in managing the disorder. And lastly, monitoring progress, and so tracking mood, stress, and adherence to therapy and medical plans. While CBT shows promise for managing anxiety and quality of life in polycystic ovary syndrome, its broader psychological and metabolical benefits remain unclear. Therefore, there is an obvious need to produce more evidence to support CBT's efficacy regarding polycystic ovary syndrome-related psychological symptoms. At present, there is limited evidence to support CBT's efficacy relative to this disorder, as few high-quality studies are available. Further, when these studies are based on self-reports, there is also a higher risk of biased results. Lastly, polycystic ovary symptoms are best managed with lifestyle interventions. Therefore, future research should focus on integrated CBT lifestyle programs and long-term follow-ups to better assess its efficacy. Thanks for watching. Bye.